Welcome to episode 20 of Dr. G at the Heart of Healthcare. I have my friend here, Dr. Lauren Templeton. How's it going?
Oh, good. Happy 20th episode. That's pretty amazing.
Thank you. I'm having fun out here educating and empowering the people.
Mm-hmm.
And you're keeping us in line with the regulatory stuff. That episode's doing good, by the way.
Oh, good. That's good. I don't have to send anybody to jail. That's fun. That's not fun.
We don't want to go to jail
No.
for fraud, not at all. So yeah, this is episode 20 of Dr. G at the Heart of Healthcare. The title is What Do We Mean by Goals of Care? My friend and I were going to demystify the goals of care and just kind of help you guys see what we're doing in hospice care when you pivot to symptom-based management and what that's all about. So we're all on the same page. So what do you have to say about this topic?
Well, I love the word pivot. I know we started talking about this based off of one of the phrases that I used with you about energy conservation, but I've started thinking about that term pivot. And I think it just is a key point that this isn't something where it has to be one way or another, or we're, in a completely different world. It's just a little bit of a shift in what we're focusing on.
Right. And I was struck by that energy conservation, guys. Just as a backstory, we were talking about that during our regulatory episode, and I never heard that term. So I wanted Dr. Templeton to explain to me what she meant, and we kind of got in this conversation. But we want to know, like, what's goals of care? Like, whose goal is it anyway? Like a game show, right? Is it the patient? Is it the family? Is it the team? Whose is it? And so anyway, that's how this all happened. And I like what you said when we talked. You said that the energy conservation is getting into a goal-oriented mindset, and it's answering the question, where and how do we want to spend our precious time, and what do we need to do to accomplish that, and how we can help them.
Yeah. And I think the first thing that I said back to you is we need to be in that mindset already, in my opinion, of where we can shift our focus to every day about what serves us and what doesn't. But when we go to energy conservation in patients who are facing very serious illness, it really truly is, what is your goal? So if your goal is to spend, let's say, well, I'm in Texas, so the afternoon at the ranch, you might have to spend some time sleeping in, or you might have to forego some of those regular activities that you may have done before, like cleaning or big breakfast, or even just those little things that, because you're sick, it's taken a lot out of you. So we have to adjust our mindset to conserve that precious energy for the moments that we want to make count.
I like that. And also a part of this, I remember while we were talking, we said, this is like myth busting again. Like, we never withdraw care. We kind of just shift the goals of care.
Mm-hmm. Yeah, withdrawing care. And then I've shifted that to say, it's not that you don't get aggressive treatment anymore. I aggressively treat pain, and I aggressively treat your goals. So just a shift to a different type of aggressive treatment and a different type of focus. We also talked about how that could be like in a dementia patient, let's say, where you as the daughter feel like you're providing loving care by having her get out of bed early every morning, and she has to be this amount of time up in the chair. But when we talk about goals and energy conservation, sometimes it's more compassionate to let her sleep in, and maybe she has less pain and less agitation and can visit with you over lunchtime. So it really is a pivot or a shift in mindset and what our focus is.
I like that. That's reminded me of last week's episode where we had the husband who happened to be a hospice nurse who was caregiver of his wife. And before she started to have the cognitive decline, and over the years of their nursing career, they would say, please don't do this to me. If I can't eat, then I don't want to be given insurers. if food is not meaningful to me, please don't do that to me. Don't give me a feeding tube. Don't do any of that stuff. But, as we know, a lot of people don't have the opportunity to express their, wishes.
Yeah. Or maybe they have the opportunity and they don't take it.
Hmm.
So I love that example that you just gave, because I can't imagine as a caregiver if I had no idea how to make my decisions. Like, what goal am I aiming for? What is quality of life for my husband? And so having those types of conversations when before the really difficult moments happen, so that you know what their goal is. Like we said, whose goal is it anyway? Is it the daughter's goal, the spouse's goal, the hospice team's goal, the hospital's goal, the nursing home's goal? All of those things, we really want to shift goals of care to be, what is the patient's goal? I love that. You know what her goal is, and it's not to have Ensure and a feeding tube. Yeah.
Right. Oh my gosh. Yeah. And then I came across this article, I'll put in the show notes. It was from a palliative program blog in Colorado, and it talked about barriers in advanced care planning. And the bottom line of the article talked about even hospice clinicians in the study expressed discomfort in discussing death and goals of care. And hospice workers identified factors to inform ACP related behavior change intervention. So if some hospice clinicians are having challenges, then I shouldn't say regular, but non-hospice physicians are definitely challenged. And hopefully, we can help them with this episode.
Yeah. And I have total empathy for that, because I know as a physician how engaged you are as a hospice doctor that, sometimes we're so attached to our patients and families. It's hard for us to say, I think there's a change coming and we all better be prepared that, it looks like mom or dad, maybe progressing quickly towards passing away. Sometimes I've been on the phone with nurses and said, how did the family take it when you talked about where we're at? And she's like, oh, I didn't quite get to that conversation. And I'm like,
Yeah.
okay, you got to turn around and go back in because we got
Yeah.
to keep everybody informed in a good way, because you want people to capture the moment. I mean, just as we say, our goals are about the patient. If we're not having those hard conversations when they're really hard, that's our job, to let families know and prepare for difficult moments as best we can.
Wow, that's literally on point with, I posted it on social media yesterday. We had our medical director of the state come by the office, and she presented to the team about the death drawing near. And I actually posted this thing coincidentally. It was the importance of prognostication. That's what we do, predicting the time. And we know that we always overestimate, but we do know signs and symptoms of when we're near the end. And so the reason she said it was important is because the people, the families, and the person, which is our unit of care, they need to do death work. And it's so sweet. Like, 4 things they said people need to say: forgive me, I forgive you, thank you, I love you.
Oh, so good. So good. I mean, and it makes a difference too. We have so many stories about those last words that you need to share, and they're just life-changing for our caregivers to go on after. And I think I've sometimes put myself in the shoes of being a hospice patient. Someday it's going to come. I want my loved ones to go on thinking well of our relationship, not, I didn't get to say this to her, or, I have guilt, or just looking back, not in a fulfilled manner with our relationship. I love that. That's so, just like you said, it's on point. Exactly.
Yeah, and they said it prevents complicated grief. So
Amen. Can you say
we're
that
gonna
again?
I know we're gonna have grief. We're gonna go through the process. It's our brain relearning that person is not here, but we don't want it to be complicated. And so I think that's so cool. And that's why we do our work, guys. Some people wonder, oh my gosh, isn't your job so hard? But it's those moments that we want each person to have, if they choose to elect for the hospice benefit. So let's get on into this. So let's see, where are we here? So we talked about the story, of how, how we frame goals of care, but I want to get more into this energy conservation. I was taking notes while you were talking, girl, on the phone. And you said it's a lifestyle. It's eliminating things that don't serve us and prioritize things that do, making choices and adjusting to a new identity over and over again. And you already gave the example. And so I like that definition. Where'd you get it from? Like, did you make it up, or was that in your fellowship, or what?
I think I'm going to take credit for that. I think that was my beautiful hospice brain kind of putting,
Yay!
yeah, all of these theories together about grace and compassion. And so, one of the things I see with my hospice patients is their loss of identity. And I always was the person to serve the meal. When we talk about our identity surrounding food, like you mentioned, the ensure. Yes. And we have such a hard time not doing aggressive type feeding at end of life. Well, it comes from a place of love, because the identity in food was mom always brought us together at Thanksgiving or dinner. Every Sunday, it was this loving, compassionate relationship. Well, you don't have to lose the loving and compassion part. You have to re-identify and remake that when she can't make the meal anymore. Or maybe the patient needs to decide, I'm not strong enough to cook, but I want to save my energy to sit down at the meal with my family. And so it really is a shift in sometimes letting go of the things that didn't serve us, to re-identify who we are and how we want to show up for those moments.
Excellent. That's so awesome. So that'll be in the show notes. So let's go into a few topics, to kind of frame this for everyone, because I think it's important for the listeners to apply it to these diagnoses and the labels and diseases that they're dealing with, so they know how contextual, how this fits into the context of their health and their lifestyle. So the first thing we had on our list was talking about dialysis, and hemodialysis or peritoneal dialysis are procedures for filtering the blood when the kidneys are not functioning, typically end-stage renal disease. And so we wanted to talk about the goals of care, because those are one of the conditions that are eligible for hospice care once the dialysis is complete. But we were talking about how people really seem to not know that there's an end time to it and when it's no longer serving you. So how long does it last? When does it stop? And how does that look?
Yeah. And so that really comes back again to what your individualized goals of care are, because dialysis for a patient, who it gives them what their quality of life is, what they want. So if it gives them that afternoon with better strength, awake and alert, not as good the next day, but then they go to dialysis again and they get that great afternoon, and that's what serves them, then that's appropriate for dialysis to continue. But when we talk about the suffering that comes from dialysis, having to be in a chair, let's say if you're going for 3 days a week for 3 to 4 hours. I lost my father to end-stage renal disease, and my mom was his caregiver. And, that was really the toughest part, especially as he got more confused, to sit in a chair for 4 hours, 3 times a week. It was very challenging. And it seemed like the intervention was not achieving the goal anymore. Mm-hmm. And so when we talk about that individualized goal of care, sometimes it's stopping what we started. And oftentimes as a health industry, I don't think we explore the stopping of it when we start things. And dialysis is such a good example. When we start dialysis, I don't hear many people saying, okay, this is going to be probably about 3 to 5 years is the average life expectancy. Of course, tons of variation there. And then you're going to have to make a decision to stop this. I don't hear that conversation happening very robustly.
I wonder why not? Like, why?
It's hard. I think it's easier to be the one who comes in with the intervention that's going to get you more life than it is to be the person who comes in and really addresses what the new life is like and the hard parts that are coming. I mean, it is easier to focus on the good stuff than it is the bad stuff.
That's making me have a flashback of, you know, there was someone that was coming to the end, and the dialysis center had met with them. This person was becoming agitated.
Mhm.
Let's see, I think desaturated, lost
Mhm.
consciousness. They called 911, and then they continued, but they, you know, it was dangerous, but they didn't want to talk to the family. So I ended up talking to the family, and I tried to have a care conference with the nephrologist. Um, but this one said, I don't have time for this. I don't
Mhm.
want to be involved. And it was challenging, and everything worked out. But and I'm not trying to, you know, make our colleagues feel bad or anything like that. But it would be nice if we just did, you know, kind of introduce the end, how the end is going to look, the trajectory of these diseases. I actually met someone last night at a networking event, and she owns a RCFE, and she talked about these people need a roadmap for how things is going to look. I was like, actually, there's palliative care. We already have that. So I'm not, Dr. G's not special. I mean, I am, but you know,
Yeah.
not that special. So anyway, yeah, so it would be nice. So anyway, that's a good example. So shared decision making, that's what that's about, team. So let's move on to our next topic. We also explored cardiology, my favorite organ in the heart. So AICDs and pacemakers, those being deactivated. What's up
Yeah.
with that?
Yeah, that's another one where I can say that I've not really heard the conversation about when we put them in, what it looks like to stop them or take them out very often. And I do think that as palliative care becomes more integrated in training for physicians, those physicians are now being trained in the skill set of having these hard conversations, which that's where our expertise comes from, that we either have training or experience in how to tackle these hard talks. I think, you know, the AICD and pacemaker thing is, it's confusing for people who aren't in the healthcare industry. It's confusing for people who are in the healthcare industry when we talk about what needs turned off, what doesn't need turned off, why, what's the difference. I'd love to hear your story about the magnet in the pandemic.
Yeah. So first of all, just to clarify for everyone, the pacemaker comes in, you know, typically like different reasons, but maybe sick sinus syndrome, the heart's too slow, or you have heart block, and they need to pace it. They need to make that electrical current go for you. That's the pacemaker. The AICD is basically like the AED you see on the wall when you
Yeah.
get shocked, you know, at the airport. So it's shocking you internally. Well, if you come on the hospice care and you die naturally, we allow natural death. We don't want to see you getting shocked,
Mhm.
anyone getting shocked around you. They're trying to
Yeah.
hold your hand, have family time. So that automatic, what does AIC stand for? I forgot. That's not even in my brain anymore.
Implanted cardiac defibrillator,
Yes, the
something
okay.
close to that.
Something. It's a
Yeah.
defibrillator. And so during the pandemic, you know, I had magnets in my car, just so everyone knows. The crash cart, when they have a code blue, I know you've watched Grey's Anatomy or ER, Age Yourself. They say code blue, and they roll this thing in there. There's actually a magnet on it. It's very large. It's like size of this pen, if you will, sitting on the crash cart to turn off any of those things, just to demagnetize it real quick. But in hospice care, when we have those patients, we don't always reach out to cardiology to turn it off. We can do it ourselves. And so I had some magnets in my car, you know, to kind of streamline the process for those visits when we had those patients. And I don't remember if I used it. Actually, I did. I put it on them and taped them on, and it was fine. Everything went well. But that's what we do just to prevent it. And so there's an end to it.
Yeah, exactly. And it, you know, of course, that's the patient or their caregiver's decision, that if there's no requirement that you deactivate the defibrillator. There's certainly not a requirement to deactivate the pacemaker. It's something we very rarely do, even though it is the right of the patient or their representative. But when our goal is purely comfort and not to be shocked, that magnet really is a quick intervention when we can't get the representative out there to help us with stopping that defibrillation.
Yes, yes. All right. Well, we're leaving the heart, my favorite organ, and we're going to talk about medications because deprescribing becomes a challenge when folks are admitted to hospice care. They have polypharmacy, they've been on medications for 20, 30, 40 years. The family says, I want hospice, but I'm not ready to discontinue any medications, which, we have compassion for that, but they just don't understand. There's been a pivot, right? In what we're doing, and we're not necessarily on that path of prevention and risk reduction of over 10 years. And so let's just talk about that because deprescribing is jarring. I remember I had a family, the daughters were just like, I wish someone would have told us. And they were referring to 22 medications that, the RN case manager and we were working on, and they were just so upset. And so I told them many months ago, I said, I'm going to do an episode on that. We're not getting an episode, you're getting this section with Dr. Templeton. But, let's talk about these medications and all these pills and all this stuff.
Yeah, I work with someone, Carrie Cooley, who's just the most wonderful educator in hospice. And she made a joke the other day that I know why mom's not eating her food. She's getting full of pills because she's on 30 pills a day. And so when we talk about goals of care, I mean, do you want to really and simply, whatever meds these are, do you want to spend all of your time sitting there with taking them at the right time and crushing or not crushing and coughing or choking a little bit on them? That's just even with that is a consideration. It can be fatiguing when people get so tired. Swallowing these big pills all day long is tiring for patients who are very weak from a disease. But you said it best. A lot of these things are, one, shouldn't be prescribed together and are working against themselves. And then two, just really even medically are not indicated anymore. They don't achieve any goal that we would want. Things like, it might help your 10-year outcome, but if we're talking about hospice care and we have a more limited life expectancy, why are we taking on the side effects, the burden of those pills when they have no benefit whatsoever? Yeah.
Whatsoever. And a new word I adopted for that is, instead of deprescribing, simplifying the med list.
I love it.
I love it. Like, let's simplify this med list so that it's just not so complicated. And we're focusing on the symptoms and things that make this person feel good every day, instead of having that pill burning and decreased appetite. So there's a few examples that are hot topics for us. So I'll just list them and you jump in there and comment on what you want to talk about. So we have the blood thinners, the Eliquis, the Pixaban, the Coumadin, the cholesterol lowering meds, the Lipitor, the atorvastatin, the rosuvastatin, the vitamins. Like, do we need that vitamin D and that calcium and all these things? And then the inhalers for those folks who have COPD, like 3 different inhalers. So let's tackle those.
Yeah. So every one of those medications could be incredible for a patient at a certain period of time. So there's nothing to say that those are all bad medications whatsoever. But when we talk about, just in simple terms, blood thinning as let's say, reducing your risk of having a stroke. If you're falling every day, when we talk about the benefit of reducing the risk of stroke versus the likelihood that we would have really bad things happen to us when we fall and we have thin blood. We see our patients all the time that, they bleed with the littlest cut, or their arms are covered in bruises because they're on these different types of blood thinners if we put them all in one group. Well, goals of care. What serves us? What's the best thing for us? And sometimes, we talk about hospice as being, we're accepting of passing away. Blood thinners to me is, I'm going to help you live longer if we get some of these medications off. They can become life-threatening. Like, let's say aggressive diabetes control. And somebody who's not eating and drinking already. Well, guess what? Your diet controlled diabetes now, and we don't have to use insulin therapy here, or we might, but we just have to reframe ourselves to make sure that they're serving us with what our goals are. at this time. I love what you said about transitioning from deprescribing, the word deprescribing, to simplifying, because I think a lot of this is about control. And so when you use the word deprescribe, it is in the control of the hospice. But when you use the word simplify, to me, it gives the family control. Like, I'm going to simplify. I want to be in a simplified position and work towards that mode. And some of this is about losing control. Honestly, we want to control the things that we can, and medications are tough for people to let go of.
Yeah, well, again, it's shared decision making, listeners, and we know that when you do come to hospice care, you've been on a challenging road. You're trying to hold on to every bit of life that your loved one has, and just know that we are with you. And there's a reason behind these things, but it's always shared decision making. We ask your opinion and we talk to you because we want to know what you think. We want to work together for the best goal of care and the best outcome for the patient. Just remember that. All right. Yeah, and those inhalers, I just want to talk about too for a sec. I know we were having a shortage of duo nebs for a while because we were just using them when folks didn't have, necessary pulmonary issues. And I remember the medical director said, just use nebulized albuterol unless they have, COPD or something like that. And so I let them know, hey, we're just you don't need those 3 different ones. They're probably not using them effectively anymore, and it's better to use the nebulizer at this point.
Yeah, so if we really get down to the effectiveness of those handheld inhalers, you have to be able to, one, understand how to use them. So if your mentation doesn't even allow you to I have to take a deep breath, exhale, inhale at the right time and hold my breath, and then exhale to get the full amount of that medication, you're not even getting the benefit from the handheld. And then some people just, their disease burden, they get so short of breath that these handhelds they're not getting that medicine in where it needs to go. And the nebulizer, to me, is just so key to letting you breathe how you're going to breathe, whether you don't get how to hold your breath or whether you can't because you're breathing so hard, working so hard to breathe with things like COPD. The nebulizers really help you more. And so when we talk about hospice, we're focusing on death. To me, that's a focus on life. I can get better symptom management with a nebulizer when you do it with the right frequency than some of these handheld inhalers.
Love it, love it, love it. Great education. And now to our final section, my little phrase that I've been saying since residency: we treat patients, not numbers. So let's deal with all these devices when people are trying to have a mini ICU at home with the pulse ox, and they're taking blood pressure 3 times a day and checking the glucose 6 times a day. And, the finger sticks and all that stuff. We don't want to leave the lungs out of this discussion, the oxygen tanks and getting extra ones just because, let's just kind of break those things down.
Yeah, I think all of that really does come back to control too. And then what do you want to focus on? So if you're focusing on comfort and you have a particular number that doesn't look right to you based off of what has been in the past, will you stop focusing on comfort? Because let's say you're used to numbers of 89, 90, 92%, and you look at your mom and she's breathing comfortably, and then you check it and it says 87. Well, what are you going to do with that number? Probably just worry about it. So it doesn't actually help the comfort part unless we're using it towards comfort. And so, sometimes we as the medical community, we want all the numbers and we don't treat the patients. And I think we pass that off to our caregivers and patients a lot, the obsession with the numbers. But it's a big shift in identity to not have to have that data. And really, you don't. The new data we want is mom smiling? Is mom breathing good? Is she achieving what she wants to achieve? And then we know we're doing right by the patient. It may or may not require more data like a pulse ox.
I love what you just said. This is the new data we want. How does she look? How does she feel? Is she smiling? Like that is so, that's it. That's it. I hope this helps the listeners. I mean, I don't want to, take the stress that the caregivers endure, lightly or seem insensitive. But I've just gotten testimonies from so many that you're just in survival mode, second guessing yourself, stress, compromising your health. I hope you get a little peace of mind from this conversation about why we do the things we do in hospice care and what goals of care means, because it's really so that you can get the most life out of the time you have remaining.
Yeah, I'm truly eliminating things that don't serve us. And really the goal, different for everybody, but mainly it's to spend good quality time with our families. And so we just want to make sure that we're aligning decision with that goal and that result versus what we've always done in the past. So yeah, and control, like we've said, is we want to keep control. And so sometimes knowledge gives us enough to let go of some of that control and really focus on what's today going to look like. And we want to do it a day with smiling and simplifying things. So yeah, I love it. I love what we do.
Yeah, yeah. And this just piggybacks on the episode I did with Dr. Roulette. She's actually a fellow at Beth Israel right now, HBM fellow, and we made a little palliative didactic for trainees. And she had some research she did during her chief year of internal medicine on helping the residents be ready to identify the surrogate decision maker, have goals of care conversations and things of that nature. So if you're listening, trainees, that's what this is about. And just improving your comfort level. You can refer back to that episode, and you don't have to be an intern. You can be an old school doctor and still learn, but just having this comfort and this ability to communicate and align with families. That's what we do. So any last words before we sign off?
No, just happy 20th. And thanks for having me. This is a fun topic, especially when you put it in terms of joy and laughing and having a good time. We took a silly picture before we started this. So I think that's perfect. That's my goal of care is to have some smiles and have a good time and enjoy life.
Awesome. And it reminds me recently, one of our senior leaders in the community said, we want these people to wake up with joy, and we have joy in doing what we do. So thank you for being here again.
Yeah, always a pleasure.
Everything you do to educate the community. And we're going to sign off. Peace, everyone.